Okay. All
Is
right.
it recording?
Yeah.
Yes, it is recording now.
Okay.
Okay.
Thank you, Doc.
Okay. All right, I'm leaving, Dr. Eljack.
Okay. Everybody. Good morning. Can everybody hear me?
Good morning. Yes, sir.
Yes, sir. We
Good
can hear you.
morning.
Good morning. Sorry for all the inconveniences.
No,
and-
don't worry. Don't worry.
Yeah, but we have to settle this issue of the email because I clicked on class 25 and the email went through. Do you have more than one email?
So Dr. Eljack, with that, you need to make sure it's so weird. You have to make sure you click on TUCVM class 2025. The regular one is for the university students. They should have clarified that for you all.
Okay, okay, we can start now. So far, we did finish with the first system in the animal body, that is the musculoskeletal system. Today, we are going to go into the internal systems, the splanchniculum. All those systems, respiratory, gastrointestinal, renal, reproductive, we are going to do those in sequence. Today, we're going to start with the respiratory system. And as you all know, the major organs of the respiratory system is within the thoracic cavity. And as we always do, we start the system by looking at the external organs of that system, okay? So the thoracic cavity is around here. Can you see the pointer?
No,
Can
sir.
you?
We just see the title slide.
Now you don't see the second slide?
No, sir. You just need to just click next, just advance the slides.
I'm sliding it. You are
You
not
click on-
seeing the sliding?
You're not clicking the arrow on your computer or like on the screen?
No, I'm seeing all the slides now.
Maybe, okay, so what you need to probably do is just exit out of sharing, like screen sharing, and then redo it again. It's probably
This is
stuck.
unbelievable. I mean, so let me go to share again. And it is here. They can't see the slides.
You need to share your desktop
I did share.
where
I went down and I shared.
your screen
Yeah.
sharing is paused. It's paused for some reason. Resume share. Now it should be visible.
Let me
Or
put.
actually it should be a new share.
Yes, it's visible. We can
It's
see
visible?
it.
Okay.
It's not in presentation view though.
Okay. He'll just put it on full screen.
No, I want to do that. Yeah.
Then next to Habib. There you go.
Now, can you see the advance of this?
Yes, sir.
You can? Hello?
Yes, we can see it now. We're on the
Okay.
second slide.
As I started, the thoracic cavity is lying within this cranial region of the trunk, which is located between the two thoracic limbs. Generally speaking, if you look at the junction of the neck and thorax, there is no line of demarcation telling us this is the end of the neck or the beginning of the thorax. But the skin in this area is very loose, and it is a very suitable site for infusion of large amount of fluid in a dehydrated animal. So if a client came to your clinic with a dehydrated dog, like a case of GDV, gastric dilatation volvulus, that we will discuss in the GI tract, the animal is critically dehydrated, so you cannot just take a needle and inject through the cephalic or any other vein. This will give you the chance to infuse as much fluid to get the dog out of this critical status. So this is one of the areas you need to bear in mind. Can you see the pointer?
Yes, sir.
Okay. Another thing, remember we discussed this here is the point of the shoulder. And if you take a line across from this point, that will take you to the ventral aspect of the first rib for line of demarcation. And you remember we sometimes put our fingers around this. We would put the palm of our hand here and use our finger looking for something. What are we looking for? What would you be looking for if you put your hand at the level of the
jugular.
point of the shoulder and your fingers start looking for something?
Cervical lymph node.
It's
Jugular
superficial
vein.
cervical lymph node.
Hmm?
Your lymph node.
Exactly, very nice. You are looking for a superficial cervical lymph node. Where would you expect to find it through palpation?
You find
Under
it deep.
the amyotransversalis muscle.
Exactly. It is always lying medial to the omotransversalis. So now these are something you need to look at before getting into the thorax itself. This point here is the tip of the olecranon, point of the elbow joint. If you take a line from this point and go up, that will put you roughly at the level of the fifth intercostal space. That is very useful landmark because if you are trying to listen to the lung sound, you cannot put your stethoscope cranial to this line. Why? What did you find in dissection lying behind this line in the cranial aspect? What did you find here? Filling the gap between the scapula and the humerus. What did you find there? That is the long head of the triceps. It is a very thick muscle. If you put your head of your stethoscope here, you will only listen to a dull sound. You cannot be hearing the lung sound. So this is a very important landmark to use as we will discuss at the end of the lecture today, how you would precisely auscultate for the sound of the lung. Another feature, remember ventrally here is the sternum and the sternibri and the flat ribs are a very good site for bone marrow biopsies. Where else would you
Eljack?
do? Yes,
Sorry, you said the sternum and the ribs, both.
yeah, and the ribs.
Okay.
Sternibri and the ribs. Where else would you do bone marrow biopsy?
Lobum
In the
and
wing of the
iliac
atlas.
Your femur and humerus.
And the wing of the atlas is the most suitable site. In large breeds and in large dogs, you cannot do it in a young puppy because the bone didn't develop yet to do a biopsy at that site. Another feature here, on the left side of the dog, just caudal to the point of the elbow, going caudally at the level of the fourth intercostal space, surgeons use that site to enter the thoracic cavity. We don't do many surgeries in dogs inside the thorax, but sometimes for removal of heartworms and other features of irregularities, your incision have to be in the middle. See, the middle of the fourth intercostal space. Why the middle? Because if you go cranially or caudally, the blood vessels and nerves are running on the caudal edge of the successive ribs. So your incision have to be in the middle of the intercostal space to avoid injury to any of the vulnerable vessels and nerves. Okay?
Hey,
Now-
question.
Yes, please.
Did you say for bone marrow biopsies, we're using the wing of the atlas?
Wing of the ilium.
Okay, cool. Thank you.
Okay. Now we go for division of respiratory system. The physiologists are going to go into this in detail, just generally for our gross anatomy purpose. We divided as the physiologists into three sequential events. The first one, breathing, that getting air in and out. That is the first stage of it. Then what we breathe in is oxygen. What we breathe out is mostly carbon dioxide. The exchange of gases at the level of the alveoli between the alveolar sacs and the blood vessels is the second stage of respiration. That blood coming in and leaving the lung will be carrying oxygenated blood back into the circulation. From there, blood rich in oxygen will reach the level of different part of the body, level of tissues. The utilization of that oxygen in the metabolic activity is the third level of respiration. So you have external respiration and internal respiration. We are going to leave it at that, and the physiologists are going to talk in details about what will happen then. Okay? Anatomically, the respiratory system consists of two main divisions: a non-collapsible tubes, and the word non-collapsible is very important because you don't want something to block the flow of air going into the lung. And the second part is within the tissues. The gas exchange at the level of capillary beds in the different tissues where the oxygen will be utilized for metabolic activity, and the carbon dioxide will be picked up by veins back into the heart. To do that, we divide the respiratory system just generally into two major divisions: upper respiratory system and a lower respiratory system. If you look, the upper respiratory system start as the nose and nasal cavity. Some people would like to consider the nasal cavity as part of the sense organ. For our purpose in digestion, in dissection, we take this as the initial portion of the respiratory system. The air would pass from the nose into the nasal cavity, into the nasopharynx, then into the larynx. We are going to do all this at the end of the semester, sometime first week of November, and the air will pass through the trachea. There are 36 rings of tracheal cartridges that will take the air until it reaches the end of the neck and the beginning of the thoracic cavity. We call that the thoracic inlet or the gate into the thorax. From there, the air will pass and we will look at it at the end of the lecture, how it divides. So
Dr.
this,
Eljack?
yes,
What did you say the craniothoracic inlet was a gate to again?
to the thoracic cavity.
Okay.
Yeah, it is the gate or inlet or door, whatever you want to call it. Okay, it is the thoracic inlet. Let us look what is the thoracic inlet. This is the thoracic inlet. If you look at the skeletal boundaries, on the top, dorsally is the first vertebral of the thoracic region. At the ventral aspect, here is the manubrium, sterni. The manubrium is the first sternibra of the sternum. The last sternibra, we call it what? We call it xiphoid. So that we don't confuse things, the boundaries for the thoracic inlet dorsally is body of the first vertebra, ventrally, the manubrium sternum, and collaterally,
Dr. Eljack?
both. Yes,
Can you please point to the manubrium?
yeah, the manubrium is the first, let me get the, this is the manubrium,
Thank you.
okay? Collaterally are the first two ribs. This is the skeletal boundary. But of course, the boundaries are covered by soft tissue. And the soft tissue on collaterally are the intercostal muscles. Dorsally, lying ventral to the bodies of the vertebrae, is the longest colli muscle. You dissected that. The longest colli run all the way from the second cervical vertebra to the fourth thoracic vertebra. So the dorsal boundary, soft tissue, is the longest colli. I mean, it is on the ventral aspect down here, okay? Ventrally, covering the manubrium, is the transverse thoracic muscle. You didn't dissect the last one, but you dissected the longest colli, and you would see it when you open the thorax, hopefully beginning of next week. The clinical importance of this thoracic inlet, you could imagine it is a very limited space. And there are crowd of structure going in and leaving. Look at it here. This is the thoracic inlet. Through it comes the trachea. Through it comes the esophagus. Through it, the big vein, external jugular, come in. All the common carotid arteries, all the nerves that we will discuss are crowded in this area. In case the dog swallow a large subject, a large potato, a large toy, that will cause compression into that area and it will create choke. The case of choke is common with young dogs and cats also. And what do you think the most vulnerable structure will be in case of choke?
The esophagus.
I beg your pardon?
The esophagus.
The esophagus have a very thick wall. You remember, it has very, maybe you didn't have it in history yet, but the esophagus is a very thick structure. It can't stand the pressure. Think wall thickness. The most vulnerable structures are the veins. The venous return will be highly compromised because they will be pressed. They have very thin wall, and that will affect the status of circulation. So please, when you dissect and they ask you, try to see the number of structure going through the thoracic inlet. So now let us talk about the thorax as a whole. What are the skeletal systems that protect the vital organs within the thoracic cavity?
Excuse me, Dr. Eljack.
Yes,
For the soft tissues, you had mentioned the longest colli and the intercostal muscles.
yes.
Were those the only two?
The intercostal muscles will be on the collateral surface. The longest colli will be on the dorsal surface, and the transverse thoracic will be on the ventral surface. Those are very good sized muscles covering the thoracic inlet.
Can you repeat? You said transverse. what?
Thoracic from thorax.
Thoracic. Okay, thank you.
Okay, so coming back to the bony thorax, there are 13 ribs and 13 vertebrae. The vertebrae are completely masked and covered by the longissimus and the iliocostalis system of muscles. You cannot palpate them easily. Each rib from 1 to number 9 joins the sternibri of the sternum. So through their cartilaginous attachment, each rib have got a costal cartilage, and that will join the sternibri from 1 to 9. Rib 10, 11, and 12. They join together in this, can you see the pointer in this part here? And that is known as the costal arch. The last rib doesn't attach to anything. That's why we call it the floating ribs. You need these when you are palpating and when you are auscultating and when you are removing fluid, thoracocentesis, from the thoracic cavity. You have to bear these numbers, and you have to bear the location of the fifth intercostal space, which ribs join the sternum directly, and which ribs join in one cartilage, costal arch, to join the sternum. Is that clear? The skeletal format of the thorax.
Dr. Eljack, could you reiterate about the rib, I guess the ribs 1 through 9? Are those the ones that join the costal cartilage? I just want to guess, make sure I'm clear.
1 to 9 joins the sternibri of the sternum. 10 to 12 join to form the costal arch. Number 13 doesn't attach to anything, and it is the floating ribs.
Okay.
Okay. What is the function of the bony thoracic cavity? You discussed that in osteology. Primarily, it protects the vital organ within the thoracic cavity, namely the heart and the great vessels, the lungs, and all the nerves within the thorax. So that is main function there. And we just talked about that the ribs and the sternum are the site for biopsy and also for formation of the red blood corpuscles. Anytime the body needs more those areas will be triggered to secrete more red blood cells. But the most important function of all this, that the rib cage expand and relax in cases of inspiration and expiration. That is what is, if that doesn't get bigger and smaller, there will be no breathing and there will be no respiration. Okay, now let us, these are the structure I just mentioned, what is within the thoracic cavity. And you can see the heart part, half part of the lung, the great vessels. We are going to learn all this muscle up here is the longus colli. You have the esophagus, you have the trachea, they are all coming here. And of course, yeah, we will talk about the lymph nodes when we deal with the cardiovascular system. So this is about the into the thorax. What is the outlet? The thoracic inlet is the most cranial entry. The diaphragm is the most caudal boundary of the thoracic cavity. What would you find at the most caudal aspect? Of course, you will find the last ribs and the body of thoracic vertebra number 13. Ventrally, this will be the costal arch. You can see here 12 to 10. That is the costal arch. And the structure back here, this is the manubrium. If you go back, this is the xiphoid cartilage, the last sternibra of the sternum. So this is generally the boundaries, so that whenever you are writing a report in any case of traffic accident or herniation, you need to bear in mind what is there. Sometimes you will see part of the abdominal organs getting through the diaphragm and come to lie into the thoracic cavity. So you have to be precise where you will describe the extent of damage to you, to the trauma of the wreck. Okay?
Dr. Eljack,
Yes?
you said the xiphoid was the last vertebrae of the sternum?
Yeah, that is, yeah. The last sternebrae is the xiphoid cartilage, and it is the caudal most boundary of the thoracic cavity.
Thank you.
Okay? Right. Now we talked about the bony thorax. Now let us talk about the soft tissue making the thoracic wall. First, we already talked about the ribs and the cartilages, and you have already dissected the muscles, right? The muscle you dissected with the fibers running caudoventrally is the external intercostal. Okay? The external intercostal fibers running exactly the same direction as the external abdominal oblique. You have to bear that in mind because both of them act to help in respiration. The internal oblique is lying deeper to the external. But one of the things I want you to put in mind, look, here is the external oblique. Can you see it? It does not go through the whole length of the rib. It ends at the costochondral junction. Costo is rib, chondral is cartilage. So the external intercostal go as far as the rib itself. It does not cover the cartilages of that rib. While the internal intercostal run through the whole length up to the ventral aspect and the mid-ventral line. So if there is a wound or something suturing needed to be done, you need to bear in mind how far does the external intercostal run and how far the internal intercostal. Going from out to inside, you have the skin, okay? You have the superficial fascia, then you have the deep fascia covering the muscle, then you have the external intercostal, internal intercostal. The most inner layer is the endothoracic fascia. The endothoracic fascia is a loose connective tissue on which the serous membrane is lining. The serous membrane is the pleura. So you need to bear in mind the sequence through which any incision is made into the thoracic cavity and at what level the incision is made. If we talked about the muscles, we have to talk about the supply to those muscles. Each muscle needs arterial blood, it needs venous drainage, and it needs nerve. You remember, no muscle would contract without the stimulation of a nerve or a hormone in case of the smooth muscle. Are you following me?
Yes, sir.
Yes, sir.
Okay, good.
Yes, Dr. Eljack, I have a question.
Yes.
What is the membrane that's lining the endothoracic fascia? I know you said it.
Yeah, we are going to talk about it. That's pleura. We're going to discuss the serous membrane in the coming 20 minutes or so, okay?
Okay.
Yeah, we're going to talk about that. We are trying to go from out to inside, and we will describe them as we do, okay?
Okay,
So,
thank you.
you're welcome. So now we did the muscles. The blood supply to the intercostal space. Remember, we are discussing one intercostal space, but the thorax is the summation of those 12 intercostal spaces. So each one represents a unit of the whole thorax. Here, the aorta would be running ventral to the body of the thoracic vertebrae. At each intercostal space, the aorta will give an intercostal artery, and the intercostal artery will run on the caudal edge of each rib up to the level of the costochondral junction. So this area from here to here is supplied by this dorsal intercostal artery, a branch of the aorta. The ventral end as the costochondral junction to the ventral end is supplied by the ventral intercostal, which are branches of this artery, which is the internal thoracic artery. So the internal thoracic give ventral intercostal, the aorta give dorsal intercostal. The area where they meet, this is where the two arteries anastomose. Anastomosis means overlapping covering of one space. Because if this artery, the ventral is very small, then the dorsal intercostal will take over and supply that area, and vice versa. So the intercostal space receives its blood supply through branches from the aorta as dorsal intercostal and ventral intercostal as branches of the internal thoracic artery. That is going to be the first artery you will dissect. The first artery you dissect is the internal thoracic, which is a branch of the subclavian artery. You will do that beginning of next week. Okay? So if the tissue receives oxygenated blood, at the end of the metabolic activity, the venous blood carrying deoxygenated blood have to go back through veins. So you can see it again here. The veins on the ventral intercostal are very easy. All of them join and they pour into the internal thoracic vein. Here it is. And the internal thoracic vein will come and open into the cranial vena cava.
Dr. Eljack,
Yes,
so are these veins found just in the internal intercostal space?
there is no internal, there is intercostal space. There is internal intercostal muscle. The space is only intercostal space. The muscle are external intercostal and internal intercostal muscles. But the space is just intercostal space. Could you repeat the question? Please?
Yes, I think I was unclear on my question. I think I asked, are the veins lying in the internal intercostal space or the external, but you just explained it, I think.
Okay, good, good. Then if you look on the dorsal surface, each dorsal intercostal artery is accompanied by a vein. As a matter of fact, most of all arteries in the bodies are accompanied by satellite vein, a vein that drains the same area the artery supply. The dorsal intercostal veins, they join on the right side of the animal only, not on the left. Both intercostal veins join this large vein on the right side, and it is the azygos vein. Could I ask one of you to remind me when we are, can we make a break or we can continue? Because we started late, okay? Can we go for another 5 minutes and then take a break, okay?
Yeah, you can continue and then take a break.
Okay, good. So the dorsal intercostal vein join to form the azygos vein, and it is only on the right side of the dog. You cannot see it on the left side. We will be seeing it in ruminants and in the pig later on next semester. The azygos vein will join all the dorsal intercostal vein from number 12 to number 5. And the azygos will open into the right it. So this is from 12 to 5. Those from 4 to number 1 do not join the azygos. They join the costocervical vein. So the whole thorax venous drainage is as such. Ventrally, through the internal thoracic vein, dorsally from 12 to 5 through the azygos, from 4 to number 1 by means of the costocervical vein. Now, this is as far as the muscles, the arteries, the veins. What is left? What is left is most important than all this, because without the nerve triggering the skeletal muscle, the muscle will atrophy, muscle will die. So the next step is the nerve supply to the intercostal space. I'm gonna stop here. We'll take only 5 to 7 minutes break because we have a lot of ground to cover. Would that be okay? Hello?
Okay. Yeah, that's fine. So we
Fine,
can
okay.
come back at like 10:07.
Okay, we will wait for another 5-7 minutes. In the meantime, if any of you have a question until the break, we will wait for the answer when everybody is back. In the meantime, please, class president, send me the official email that I can correspond with you as a class at the end of this lecture. I will appreciate it. Can you hear me, Brianna?
Yes.
Thank you.
Dr. Eljack,
Yes.
so this is not a question in regards to what we're going over now, but
Yeah.
I've been looking for the videos that you said for the vertebrae column from last year, but I'm
Yes.
unable to locate that. So can you help me find it? Because
Yeah,
I
I'll
looked
tell
on
you.
the streaming out, but it's not there.
Okay, I'll tell you what. We used to have what we call media site. It was a platform have been running for as long as I have been here. The college decided to remove the media site from its location, and the Office of the Student Affairs said they have copied all the videos. You talk to any one of the people in the student side, okay? I don't know who is in charge of this, but one of them will give you either the website or the recording itself. I don't have any, I didn't use it myself after the media. I used to access media sites to go through the lectures and make any correction, but I'm sure ask anybody in the student affair, go to Dr. Tippett, he will direct you to whom you should talk to.
Thank you so much.
You're welcome. Can we, is it over now or not yet?
Can we get like 2 more minutes real
Oh,
quick?
yeah,
Like
we can-
everybody's
we
just
can give
gathering
more than
themselves.
3 minutes, yeah. We can
Okay.
get more than 3 minutes, yeah.
Oh, perfect.
Okay, we can start now, okay? So far we are talking about the thorax and we discussed the boundaries of the thorax. We talked about the entrance into the thorax and the most caudal exit of the thorax. And we are trying to talk about the wall of the thorax, and we already went through the muscles making the wall, and we talked about the vessels supplying those muscles. The most integral part of this supply is the nervous supply, because without a nerve supply, the muscle will not contract. So tomorrow, when we discuss the autonomic nervous system, the beginning of it is, I'm going to just to go through it in a very broad way. You know, for the whole body cells, trillions of them, to work together and make the animal body live and move, they have to have a center of coordination. They have to have a place where these cells can integrate and work together for the major reason of maintaining the correct homeostasis for the animal. The center of coordination is the brain and the spinal cord. That is the headquarters sending the commands to the trillions of cells of the body. How that command reach the different parts of the body is through nerves. A single nerve is a neuron. Those cells are specialized by sending electrical stimulus or an electrical message through their axons. Those nerve cells are known as the peripheral nervous system. Peripheral because they are not central. And we recognize two types of peripheral nerve. Those arising from the base of the brain are the cranial nerve. And there are 12 pairs. Those arising and connecting to the spinal cord are spinal nerves. There are 36 pairs of them. We're going to go through each one. How do they form in the spinal cord? Because now we are trying to supply the intercostal space with nerve fibers to trigger the contraction and relaxation of the intercostal muscle. This here, can you see? Can you see the cursor? This is a cross section of a spinal cord. I'm sure you have seen this in your high school. You have seen it in your biology 1 and whatever biology courses you have taken. This is the spinal cord. The spinal cord and the brain will not be taught this semester. Both of them are the subject of neuroanatomy at the beginning of the spring semester. So now here we are only dealing with peripheral nerves. Each spinal nerve is formed by two roots. You can see it here. There is a dorsal root and a ventral root. The dorsal root is completely sensory in nature. When we say it is sensory, it is afferent. It brings impulses into the central nervous system. The ventral root, which is here, is motor or efferent, that taking the command from the spinal cord to the different effector organ. This here is the vertebral canal. You have read that in osteology, right? The union of the ventral root, which is efferent, and the dorsal root at the intervertebral foramen will form a spinal nerve. That is very basic, what I want you to know now. Tomorrow we will go into details about this. Each spinal nerve.
Dr. Eljack?
Yes.
So for the dorsal and the ventral root, did you say that they're connect to create a spinal net, which is indicated there in 22 and 25?
Yeah, they form the union of the sensory fibers in the dorsal root and the motor fibers in the ventral root. The union form a spinal nerve. So it is a mixed nerve carrying thousands and thousands of fibers, both sensory and motor. What we're going to look at is so. Here is the formation of the same spinal nerve, and you can look at it here. The spinal nerve will split when it comes out of the intervertebral foramen into a dorsal ramus. The term ramus means branch. The dorsal ramus will supply this muscle you dissected last week. The longissimus system, the iliocostalis system, the semispinalis system. The dorsal branch of the nerve supply all those muscles for contraction. The ventral branch, so I want you to remember, there is ventral root and dorsal root. Don't confuse it with dorsal ramus and ventral ramus. These are two different structures. The ventral ramus will supply the hip axial muscle. those muscles lying below the transverse process of all vertebrae. The muscle dorsal to the transverse process are epaxial. The muscle below the transverse process are hypaxial. Okay, hypaxial and epaxial differentiated by the transverse process. As you can see, each nerve will come and supply motor fibers to the intercostal muscles, and they will carry sensory fibers back to the central nervous system. So you have a dorsal branches and ventral branches. If we look at it here more diagrammatically, okay, we don't have the dorsal root clearly drawn here, but this is the intervertebral foramen, and you can see the spinal nerve coming out. It has a dorsal branch supplying primarily the muscles on this region and the skin of that region. Epaxial muscle supplied by the dorsal ramus. The ventral ramus supplies the hypaxial muscles, and those are the external and internal intercostal muscles. Is that clear to everyone?
Dr. Eljack?
Yes?
So would you say, like, I guess the ramus is mainly, I guess, like, innervating, like the muscles near the thorax region?
Yeah, it depends on each region. I said spinal nerve. There are thoracic spinal nerve, there are cervical spinal nerve, there are lumbar spinal nerve, there are sacral spinal nerve in the pelvic cavity. So each region have a spinal nerve and more than the spinal nerve. If you can see down here, there is a branch here. That is not part of the spinal nerve. That is the ramus communicans, which is part of the autonomic nervous system. We will go through it in following lectures. Did I answer your question?
A little bit. I guess I just want to make sure, because I know we're on the nerve supply of the thoracic wall, correct?
Yes, the intercostal nerve.
Okay,
at
and
each
so,
intercostal space supply the intercostal muscle in the intercostal space
okay.
and
this
the
is
skin of that area.
right.
Okay. Any other question? Okay, let's move. So here we talked about the same thing, and here you have what is the, you remember earlier I said at the level of the left fourth intercostal space, you make the incision in the middle of the space to avoid cutting any of the vessels or nerve because they are all running on the caudal edge of each rib. Okay? Can you see this here? Hello?
Yes.
Yes, sir, we can see it.
Okay, good. So this is where you need to pay attention. Okay, now we finished with the bone structure of the thorax, the boundaries of the thorax, the wall musculature of the thorax, the arterial supply, the venous drainage, and the nerve supply. Now we want to know what is lying inside the thoracic cavity. And before I go further, I want you to pay attention. The thoracic cavity is not the pleural cavity. The abdominal cavity is not the peritoneal cavity. We are going to focus on the thorax. And to explain to you how are different organs lying into the thorax, I have to go back and just say a little bit about the development early in embryology. Early in development, when the zygote is going to become an embryo, the whole cavity is called the coelom. The coelom, excuse me, is all this space. Later in development, the dark line is the diaphragm, will develop and separate the thoracic cavity cranially, see, thoracic cavity cranially, the abdominal and pelvic cavity caudally. During early stages, this coelom is lined by a single layer of cells. You learned from Dr. Goyal, single layer of cell is simple squamous epithelium, right? Huh? Nobody's answering. Did you get simple squamous epithelium?
Yes.
Yes.
Yeah, okay. When the simple squamous epithelium is lining a cavity, what do you call it?
Endothelium.
Huh? Body cavity?
Oh no, my bad. Meso.
It's called mesothelium, right? What do you call the endothelium? What does it line?
Lines the blood
Blood
vessels.
vessels.
It lines the blood vessels. We are not talking about blood vessel, we are talking about a cavity. So the whole coelom is lined by a single layer of epithelium known as mesothelium, or we call it the serous membrane. The term serous membrane indicates a one layer of cell covering and lining the cavity. Why do you need that? It is needed so that the developing organs can easily slide on each other without adhesion. Smooth movement of organs on each other. If you look at it here, this is the thoracic inlet, this is the thoracic outlet. You can see the intercostal space, you can see the ribs. This lining inside the cranial aspect of the coelom is the pleural cavity, and within the pleural cavity, you will have the pericardial cavity. Okay, let us move one step further. Here is the same coelom, and here is the lining epithelium. I know those of you who have taken embryology, the early primordium of the embryo have got 3 layers of different types of cells. You have an ectomysium, you have an endomysium, and you have a mesomysium. Those are the 3 layers from which the whole animal developed. Dr. Goyal will cover that sometime at the end of the semester, okay? What I want you to pay attention to, that see, this is the whole embryo. You can see here the area within the thoracic cavity. This is the area within the abdominal cavity. And back here is the area of the pelvic cavity. So the lining coelom mainly line the coelom cavity and keep the organ smoothly moving. For us to understand how they do that, we have to look at we made a transverse section through the embryo. This is the wall of the embryo. This is the coelom down here, the empty cavity. The dark line here represents the lining mesothelium. In the abdominal cavity, because you can see there is gut here and so on, the part of the coelom lining the wall, we call it parietal. Parietal means wall. And it is called peritoneum. We will talk about the pleura shortly. So the part lining the coelom cavity, see, it is very big early in development. Then the different organs start to develop. They develop by pushing the parietal peritoneum with them into the coelom. So now the part covering the organ is called serous visceral peritoneum. The one in the wall is parietal. The one covering the organ is visceral peritoneum. The part connecting the parietal to the visceral, this part here, is the mesentery. If it is a gut, if it is like a uterus or a kidney, the kidney is up here. Instead of calling this mesentery, we call it ligament. See, we are confusing things. Remember the definition of a ligament so far we had in the musculoskeletal? Attaching bone to bone or attaching an organ to a wall within the viscera. Did I miss you or are you following me?
Dr.
We're
Eljack,
following.
Huh? Yes, go ahead.
yeah, I'm kind of unclear. So I know you said this is a cross section of an embryo, correct?
Right.
I'm just kind of confused. Like, why is the uterus like there? So is like the embryo? I know the embryo obviously sits in the uterus, but
We just gave it to you as an example. It would be very small, but to differentiate between a ligament and a mesentery, the term mesentery is mainly assigned to that of the intestinal tract. The part to the stomach is called omentum. The part joining the stomach is not called mesentery, it's called omentum. Like the kidney. See the kidney here? The kidney in all mammals is retroperitoneal because it is not surrounded by serous membrane. It is only on the ventral aspect of the kidney. This is why the kidney is retroperitoneally located. Yes, somebody else had a question, go ahead. No? No questions? I'm just trying to give you the baseline for terminology. We are going to go and understand how the lungs of the heart are sitting in the thoracic cavity. Okay? Can I move? Okay, here we are. These are the serous membrane of the body. In the thoracic cavity, it is lined by pleura, and then that part is the pleural cavity. In the abdomen, it is lined by peritoneum, and it becomes the peritoneal cavity. Both abdominal and thoracic are a continuous layer of mesothelium. The heart have got its own serous membrane, and it is not inside the pleural cavity. It is sitting in the mediastinum, and we will see that shortly. Now, here is general. Now we are going to talk about the thorax and the pleura. This pleura is the serous membrane of the thoracic cavity. It lines the walls of the thoracic cavity. Okay? It is a very important part of the whole mechanism of respiration because it is lined by several receptors. Tomorrow we are going to explain what is a receptor. A receptor is the sensory area of a nerve that really pick up the change in environment. Any environment change have to be dealt with by the central nervous system. So whether it is the mucous membrane in your mouth for taste, or the mucous membrane in your nose for smell, the mucous membrane under your skin for touch, all these receptors detect the change in environment and send it to the central nervous system to do something about it. So let us move and see how it happens. Now, this is the cross section of the thoracic cavity. Early in development, the coelom of the thoracic cavity is divided into two cavities. One on the left, one on the right. They are separated by a connective tissue area. So the coelom of the thorax is not like the peritoneum of the abdominal cavity. There are two sets of coelom in each left and right side of the thorax. The space between the two is not a coelom, it is a connective tissue area. Had lots of collagen, elastic, fibrous, and all sort of connective tissue. The bud, the early primordium of the lung, the early primordium of the heart, are located within the mediastinum. Look at this fellow here. Here, this is the primordium of the lung. The trachea, you remember, we saw it coming through the thoracic inlet and bifurcates into two principal bronchi. The trachea developmentally is one structure with two principal bronchi. Each one will start growing. Look, it grow and it push into the different two pleural cavities. See now, the whole thing is the thoracic cavity. The empty space here and here early in development are two pleural cavities because they are lined by one layer of cell on each side. We have two pleural cavities. Early in development, the primordium of each principal bronchus will start growing here and here. That will lead to the lung going this way. To go and describe the different parts of the pleura, we said, remember, in the coelom, the one close to the wall, this is parietal pleura. Okay? The part covering the diaphragm here is the diaphragmatic pleura. This part here, within the wall of the mediastinum, is mediastinal pleura. It is one layer of cell. They are not divided. It is a continuous layer of cells. The part close to the ribs and the intercostal muscle is the costal pleura. The part covering the diaphragm is diaphragmatic pleura. The part lining the wall of the mediastinum is a mediastinal pleura. It is a continuous layer. There is no line of demarcation between costal and diaphragmatic, but we call it according to the structure they attach to. So, what is the pointer pointing at? What structure here? What is the structure here?
The costal pleura.
Come on, class, help. The endothoracic fascia. We mentioned that earlier. Remember? We said after the muscle layer, there is a loose connective tissue area, endothoracic fascia in the thoracic cavity, and transversalis fascia in the abdominal cavity. They are the supporting tissue for the mesothelium of the pleura. So now let us go here and see.
Dr. Eljack,
Yes,
could you point out the endothoracic fascia again?
is the space between the serous membrane and the wall. The dark line is the skin. The fuzzy layer are the two layers of muscle, and the very edge of it is the endothoracic fascia where the pleura is sitting. If you look here, see now, this was completely straight line. Now the principal bronchus starts to grow out and the lung tissue pushes. Okay, follow it. See, we'll call this mediastinal pleura, right? That is here. Then the mediastinal pleura is pushed by the lung. So the part covering the lung is no longer parietal. It is covering a serous membrane. It's covering a lung. So it is a visceral pleura. Another term for visceral pleura is pulmonary pleura.
Dr. Eljack?
Could you repeat that?
Okay. We said this is the mediastinum, just like here. This was straight line. It is here, mediastinal pleura. Then it gets pushed by the lung. So the part covering the lung is no longer parietal because it is covering an organ. So it is a visceral or pulmonary pleura. Look what happened. This was a big space, right? Coelom. Look how it is small now, where the pointer is. That is what is left of the pleural cavity. So there is no organ within the pleural cavity. It is just a potential space. No organ whatsoever. What is there in that space is just few milliliters of serous fluid to lubricate the surface of the lung and the surface of the costal pleura. Remember, sometimes during the winter, if you are not warmly dressed and you walk a block or two, sometimes when you inhale, you feel there is like a very sharp pain. That is because the serous membrane have been affected and is inflamed. So anytime you inhale, the parietal pleura will be touched by the visceral pleura, and the sensory ending of the receptor will make you feel the pain. Anytime you have an inhale, there is a sharp, very localized pain in an area, and that is pleuritis, inflammation of the pleura. Let us go and see here. So now we talked about all these. The third one is the pericardium. This doesn't really correspond with this. The pericardium, we will talk about it when we do the cardiovascular system, how it develops and what are the different layers. Okay, but we already discussed this, connecting peritoneum in the abdominal cavity. It is the mesentery when they suspend an intestine, and they are ligament when they suspend an organ other than the GI tract. The ovary, the uterus, the cervix, all those, the urinary bladder are called ligaments rather than mesentery. Okay. Please, one of you stop me when we come to the time. Again, I'm gonna go through this. Early in development, the thoracic cavity is lined by two empty pleural cavities. As development progress, this primordium of the lung, you can see it, it start pushing. The part of the mediastinal pleura that is pushed by the developing lung is no longer mediastinal, it is visceral or pulmonary pleura. And you can see the growth of this tissue is in the expense of the space of the pleural cavity. It used to be a big space, but the lung pushed and it becomes smaller. It pushed and it become only this. And this is exactly what we say there. If you look down here, this is where the heart develops. The heart is developing within the mediastinal space, within the wall between the two pleural cavities. Okay, so this is how they develop. If we look at it here, too,
Dr. Eljack,
yes,
I'm sorry. So yeah, the picture number 13, you said that's the development of the heart. When does the mesothelium surround the heart?
because I said I'm going to do that when we do the cardiovascular, because I will talk about epicardium. The same mediastinal pleura will be there, and then the fibrous pericardium, a layer of connective tissue, and the parietal layer of the pericardial cavity. If you leave it at this point, you will be better off until we discuss the development of the heart. Okay? Can we leave that? Remind me and ask me the same question when we do the heart, okay? We don't want to get stray away from our focus, all right? Okay, so here, now it is not moving. Why? Yeah, okay. So we talked about the pleura and we said visceral because it is covering the lung. And there are some parietal pleura and connecting pleura. The parietal pleura, we already said that lining the ribs is costal, that covering the diaphragm is diaphragmatic, that lining the wall of the mediastinum is mediastinal pleura. If we talk about the connecting pleura, then we are talking about a pleura joining the parietal to the visceral pleura. Here we are. What kind of a section is this?
A cross section?
Ah, you think so? Look, before you answer, look at the ribs. Okay, let me go back. This is a cross section, right? But if you look here, is this a cross section?
Longitudinal.
Longitudinal, do you think?
Transverse.
Is this a transverse? Guys, I ask you to go and read medical terminology. This is going to hurt you if you don't. This is a dorsal view, a dorsal section. We cut the dog transversely on dorsal and ventral part. It is not a cross section. because you can see here is the thoracic inlet. This is the first ribs. Remember we talked about them? We said they are lined by intercostal muscles and dorsally by the longus colli. We don't have the longus colli because the section is a dorsal section. And look at your manual for the dissection of the dog. The first few pages, they have a diagram showing you this. So this is a dorsal cut. The transverse cut comes like this, like the one we have seen last lecture. So here are the intercostal space between the ribs. Here is the diaphragm. Remember, this is the early development, the very large pleural cavity. Remember? And then we said this here, because it is on the ribs, this is costal pleura, costal parietal pleura, and this part here is diaphragmatic parietal pleura. This is mediastinal pleura, and the space between the left and the right pleural cavity is the mediastinum. All organs in the thoracic cavity is lying inside the mediastinal space. No organ in the pleural cavity. Are you following me? If you look here, this is the primordial passing. We said here, this is mediastinum. This is the principal bronchi when the trachea divide. So up to here, it is mediastinal. Here, because it is covering the lung and the bronchi, this is visceral or pulmonary pleura. The class is silent. There is a problem. Look here. This is a later stage. The lung developed even more. Instead of having all this, now it has only this space. Look at it. Because here is the endothoracic fascia. This is the costal pleura, and this is the pulmonary or visceral pleura. This is what we refer to it here. We have seen each one except this. Connective pleura, it has to join the visceral pleura with the costal or diaphragmatic or any parietal. It has to be a connection between two parts of the serous membrane. Okay?
Okay.
Yes?
Yes, sir, we're good.
Good. I don't know what just happened here. Okay. For some reason, I got stuck here. I must have touched something I shouldn't have, and I can't get out of it. Any help from you guys, what I should click on? Nobody knows what I should do?
I'm not really sure. I mean,
Yeah, me.
yeah, call me.
Oh, mean. I must have hit something I shouldn't have. I got stuck here and it's the presentation is not moving.
Oh, it's not moving. PowerPoint?
Yeah.
The mouse is. There's something wrong with your laptop. Your laptop is overheated.
Oh,
Dr. Eljack, would you like to take a break? Because it seems
yeah,
like
take a break and let me work on
yeah, we need to let that computer cool down. So
Okay,
let's
sure.
take some time.
ممكن تاخدها في مسند يا بابا. Look at the residual heat من تحت. That's why the mouse isn't working. You can't put it on something like this. You have to put it on something that's flat.
Okay.
ازاي يحطها؟ The video is on, by the way. I accidentally turned it on. But the mouse isn't working. See?
Working. Sometimes it shows up, sometimes let me. See, there are two layers, why here and here? I don't want to see. Cover it. خلينا تكويت من تكويت الحكايه كلها فورس كويت يلا لا ما في بوينت شايف يا ما في كيس صغير.
You have all of these programs.
ما يمكن دي رنم
ما
وزي
ودي ذلك في الحاجات اللي بتعمل.
ما دي كانت مقفوله ظهرت هسه كانت من قبل شغاله ما شغاله
Cisco View.
دي كلها كانت كده.
Now the mouse is on. So close the video here.
خلينا نسوي دي بالأول.
عشان ما يعيني ده. Stop the video here.
ما افتكر لسه تعرف كده شير ما دارين ما نرجع في الحكايه دي.
You're still on share screen.
يا بس شير
انت قلت ده
انت فيها صوت تتكلم ما في
ما في
كده
because
ادينا
it's closed.
كده ادينا شوف
Hold on. Okay, you need to open your PowerPoint. It's this, it's the thorax, right?
Yeah.
It's open.
Now that's good. Thanks.
Now you have to go back to the slide that you want.
Yeah. And then you're here.
Now go to the Zoom, go to Chrome.
Why is it not there?
Yeah, this is Zoom. Share screen. Now it's here. Deal with it. This is a slide, that's the beginning.
اي واحده فيهم انا برجع بيها سويت خالدين في واحده انا بس this is I don't need type this line. Can you hear me there, anyone? Am I connected?
Yes.
Yes, you can? Good. Yes, good. Then we are back. We still can take another few minutes and we will go and do the last part. Can we start now?
Yeah, we
Hello?
can start.
Yeah?
Yeah.
Okay. So we said we dealt with all these portions over one continuous layer of mesothelium on the right side or on the left side. Think of it. We just give them different names. But what you see here is the same as you see here, is the same as you hear. It is a continuous layer of serous membrane over one layer of cells, a simple squamous epithelium. We call it mesothelium. To get into this, connecting pleura, in general, it has to be a ligament joining a parietal layer to a visceral layer. So if we go here, This is the right lung. Okay, we will talk about this loop. But look here, this structure joining the right lobe of the lung to the mediastinal pleura is a pulmonary ligament. There is one on the right. And then when we dissect the caudal vena cava, when it comes through the diaphragm from the abdominal cavity into the thoracic cavity, see, I didn't say pleural and I didn't say peritoneum. I said cavity, thoracic cavity, because this is a vessel and it is covered by adventitia. It is not covered by serous membrane. At the level of the diaphragm, the caudal vena cava is known as pilica vena cava. We are going to dissect that in the cadaver, and we will see it in relation to this accessory lobe of the right lung. It is going to be at this level. This is the pilica vena cava. Okay, now let us go and talk about the parietal layer. We know costal parietal, diaphragmatic parietal, mediastinal. All of these are division of the parietal pleura. Look at it here. Can you see the cursor? Look, this is the costal pleura. This is the mediastinal pleura. This is the thoracic inlet. On both right and left side of this thoracic inlet, the costal pleura and the mediastinal pleura comes all the way outside here on both the left side and the right side. They are in the form of a cup. That is, we call it cupula pleura. It is a very important part of the extension of the pleura because it sits outside the thoracic cavity. It sits at the base of the neck, outside the thoracic inlet. You know why? Because if for any reason, unfortunate or a traffic accident, this area just front of the thoracic inlet is punctured wood, that will lead to what? If this here or here being punctured, what will happen? Guys, it will lead to the collapse because you will lose the vacuum between the parietal and visceral layer. That will lead to the collapse of the lung. And it is a very serious problem. Copula pleura. Usually it is longer on the left side than on the right side. And we said it is important because if they are punctured at this level, they are lying outside the thoracic inlet. That will lead to losing the vacuum between the parietal and the visceral layer of the lung. This is visceral. You puncture this, this will collapse. So does the lung. Okay, so now we have other issues dealing with the pleura within the thoracic and the pleural cavity. If we look at this is a good diagram to follow. This is your first rib and you count all the way to the 13 ribs. Of the things that we want you to remember, we said that pleura covers, let me move this from here without making any damage, okay? See, this here is the diaphragm, the most caudal aspect, and it is covered by pleura. This is thoracic, this is the thoracic inlet. The pleura is lining the ribs. When it reaches this point, it becomes reflected over the diaphragm because it is a continuous layer. Are you following me? Imagine
Yes, sir.
that the ribs are lined inside by parietal costal pleura. When the diaphragm bulge, can you see it? The diaphragm bulge at this level here. Count the ribs from there to here. 1, 2, 3, 4, 5, 6, 7, 8. At the level of the 8th or sometimes the 9th costochondral junction, the pleura from the ribs will be reflected over the diaphragm. Look at it here. We call this the line of pleural reflection. The pleura reflected from being costal to become diaphragmatic because the diaphragm bulge inside up to the 6th intercostal space. Why is this line important? Because if I take a needle and insert it behind this line, I will be in the peritoneal cavity. If the needle, I take it and make it go cranial to the line of pleural reflection, I am in the pleural cavity. It is a very critical line. You have to measure and count the ribs exactly. Why I'm saying this? Because sometimes some fluid will be here and you want to aspirate that fluid so that the lung can expand and collapse without any problem. If there is a fluid, the alveoli don't have the power to push through that. Are you following? The line of pleural reflection reflects what the pleural lining of the ribs become reflected of the pleural covering of the diaphragm. Let us look at it again. Okay. We said that one here is the line of pleural reflection. Then now let us see where is the base. The lung is here, sitting throughout the thoracic cavity. Again, this is thoracic inlet, and you count. If you count 5 from number 6 and make a straight line to the 11th, not the 12th, not the 13th, not the to the 11th. That will be the basal border of the lung. What does it mean? It means at maximum inspiration, when the lung is maximally inflated, large, had a lot of air in, that is as far as the base of the lung could go. As a matter of fact, it is few centimeters ahead because the very end, the alveoli are very small and very little in number, and the edge is very thin. Even if you want to listen to the lung, you won't be able to listen to it exactly at that line. It have to go a little bit further, and we'll talk about it shortly. So let us go back to the same diagram here. This is rib number 6, and this is 11. So the line here is the basal border of the lung. The line here is the line of pleural reflection. Okay? When the lung is maximally inflated, this space, the lung will never come and cover this space. The space between the basal border of the lung and the line of pleural reflection, it is known as the costodiaphragmatic recess. Costodiaphragmatic recess is this space, and it is a very vital space. Why? because during illness, if the lung have got a pathological issue, like if trauma hit the dog and the lungs start bleeding, the blood is going to accumulate only in this space. This space is where all the fluid will accumulate in any of the pathological component. And we said the basal border is from 8 to 9 up all the way to the 11th. Okay? If we go and look at this, here it is. 7 to 8 space goes up. So you count all this, it is up to here. And then the fluid accumulating in the space between basal border and the line of pleural. This space is costo-diaphragmatic space. The fluid always accumulate by gravity in this area. So in case you want to remove fluid from this space, it is known thoracocentesis. Remember, we have arthrosynthesis for joint, thoracocentesis for the thorax. Where would you insert your needle to remove the fluid? It is always at the level of the 7th or 8th costochondral junction, at the level between the junction of the rib and the costal arch, costal cartilage, the fluid will be, and it is very easy to withdraw the fluid, whether it is blood or serous fluid or pus, any kind of fluid there, you will aspirate it at this level. Are you following this? This
Sir, I
is-
haven't-
Yes.
If you don't ask me, because I assure you, the next test, not this one, there will be at least 2 questions about these clinical conditions. At least 2. So you need to understand, we are trying you to know why you are doing thoracocentesis, where will you do it in the dog, where will you do it in the cat. The cat, it is always at the 7 costochondral junction on both sides, left or right, it doesn't matter. The
Dr.
dog,
Eljack?
it is 7 or 8 intercostal space. Yes.
Okay, so just to clarify, you said that the fluid will accumulate between like the line of the pleural reflection and the basal border of the lung ventrally in that space.
That space is called costo-diaphragmatic space. What you just described between the basal border of the lung and the line of pleural reflection, that space is known costo from ribs, diaphragmatic from diaphragm, and it is a space between the two. Yes, go ahead.
Okay, and so my question also would be, so you mentioned the importance of the line of the pleural reflection for not auscultation, but if we wanted to use a needle in there, could you not use that line of pleural reflection for this buildup of blood from a pathological lung as well?
Yeah, but this is the same thing we're talking about.
Okay,
It's the
thank you.
same whether you insert a needle. I just mentioned it at the beginning because we didn't have the thoracocentesis yet. That needle is thoracocentesis. If you put your needle in this case behind that line, you are not in the costodiaphragmatic system. You are
Okay, I got it.
You are in the peritoneal cavity. Is everybody with me?
Yes, sir.
Okay, I would assume you are okay. Then let us go and see what. This is what are the pathological conditions that will have, you see the fluids here in this space. Hemothorax referred to blood accumulation in acute trauma to the thoracic wall. Hydrothorax, in cases of emphysema, the acute stage of the early development of the disease, there will be fluid secretion, and you need to remove that fluid, because if you don't, you are obstructing the inflation of the lung, any of these cases, okay? Biothorax, this is in advanced cases of emphysema when the condition is chronic. Those fluid will become pus, forming fluid due to the microorganism in that fluid. Pneumothorax, this is, what will pneumothorax you think is going to lead?
Collapse
A
lung.
puncture wound, and it will lead to the collapse of the lung, because you are putting air between the line of pleural reflection and the basal border, just the same as when we puncture the copula pleura ahead of the thoracic inlet. Okay, that is air. Chylothorax, as we will learn in next week, the lymphatic vessels carrying all the lymph from the pelvic cavity, pelvic limb, abdominal cavity are carried by a vessel known as the thoracic duct. If in a trauma, that thoracic duct is ruptured, the lymphatic fluid in the thorax is known as chylothorax. Please pay attention to this, okay?
Say, sorry, can you repeat what chylothorax is?
Is rupture of the thoracic duct, which carry most of the lymph fluid from the hind limb all the way to the thoracic cavity. We will talk about it in cardiovascular. If the lymph is coming from the head, neck, and the thoracic limb, they don't come through the thoracic duct. They come through the tracheal duct, right and left. They join the cranial vena cava or the external jugular vessels and open into the cranial vena cava. We'll talk about it. Okay? All right. If you look here, this is the cranial lobe on the right side. This is the caudal lobe. See the space on the right side between the cranial lobe and the caudal lobe. There is no lung tissue. We call this space as the cardiac notch. And usually is done or used for cardiac puncture. If you want to put a dog to sleep in a hurry, that you don't have to go through the whole thing. The left ventricle will be here, and you not the right ventricle. The left ventricle will be here, and you inject your medication at this side. There is a cardiac notch on the left side, but it is very limited in space. The one on the right lung is very clear. Okay. Now we come to what is going to be the end of this talk, hopefully. The trachea, we said the first ring is lying just behind the cricoid cartilage of the lung, of the larynx. Okay. If you count these from there until you reach this point, at the base of the heart, dorsal to the base of the heart, the trachea will split into two principal bronchi. Each one is a bronchus. The two are bronchi. The side where the trachea split here is called the carina. Why I mention it? Because sometime in older dogs, the cartilage of the carina ossify, and it gives you the false impression that there is a break of a bone there. The carina is the point of division of the trachea into two principal bronchi. On the left side, okay, this principal bronchus divide into only two lobar bronchi. On the left side, the principal bronchus divide into two lobar bronchi, a cranial and a caudal. On the right side, the principal bronchus divide into four lobar bronchi, a cranial, a middle, a caudal, and an accessory. Very straightforward. On the left side, principal bronchus divide into a cranial and a caudal lobar bronchi. Each bronchus ventilate this area. In case of the left side, the left lobar bronchus divide into a cranial and a caudal part, that is secondary bronchus. In case of the right side, the principal bronchus divide into a cranial, that is a cranial lobe, a middle lobe, and then a caudal lobe and an accessory lobe. If we go and look at this, here they are. Now the left side is on the right here. This is the right side. This is the trachea. This is the carina. This is the principal bronchus on the left side, principal bronchus on the right side. On the left, it divided into two lobar. 1, 2. The first one divided into a cranial and a caudal lobes. It means it supply on the left side a cranial and a caudal lobe. And then the caudal bronchus gives the caudal lobe. So on the left side, you have only a cranial lobe divided into a cranial and a caudal portion and a caudal lobe. However, on the right side, there is a cranial lobar to give a cranial lobe. There is the middle one giving a middle lobe. There is a caudal one covered by this and a caudal lobe, and then this one is the accessory lobe. When we do the dissection looking for the pilica vena cava, we are going to see it attached to this accessory lobe of the right lung. Are you following me? Okay.
Yes.
You are not
Yes.
answering. I assume you are. Okay. So if you look at the lung, each one is sitting in a pleural cavity or a pleural sac. The trachea, of course, is sitting in the mediastinum. Only the lobar bronchi are within the pleural cavity. If you look at it, each lung is separated from the other by means of the connective tissue wall, which is the mediastinum. If we look here, the lung, this is the head here, the tail is back there. This is the apex of both lung pointed in a cone shape. The obtuse wide surface here, this is the caudal. Now I want you to follow the cursor. Look, the space here, okay? See? Surrounding all these structures going in the lung or coming out of the lung. This is the hilus of the lung in both areas, whether it is on the right lobe or on the left. All of these are what? Are bronchi, arteries, veins, and lymphatic. All of them collectively are the root of the lung. Same thing here. Hilus, outside the structure are the root. If you look, this is the right lung. This is the cranial lobe, the middle lobe, the caudal lobe, and the accessory lobe. On the left side, only this is cranial here about it, because the cranial lobes have two portions to it, and the caudal lobe have got only one. This is primarily, I think, all we have. Now we are coming to the practical aspect of these lines. Mainly having your stethoscope around your neck, the times you are going to use it. If a dog is brought to you with some respiratory issues, it could be emphysema, it could be one of the conditions we talked about, pylothorax, hydrothorax, or hemothorax, you are going to auscultate, to listen to the sound of air going into the alveoli and air coming out of it. Blindly, we already said at the beginning of the lecture, this is the point of the elbow, and a straight line up is a no territory. You cannot go cranial to that line because the triceps brachii muscle are a thick layer of muscle. You put your stethoscope cranial to this line, you get a dull sound. You are looking for a resonance sound. If there are crumples, if there are dull parts and crumpled parts, you want to listen to the lung around here. The dorsal boundary of this triangle, we said this is the cranial boundary. You remember the muscle we dissected, iliocostalis lumborum, longissimus lumborum, the edge of it is the dorsal boundary up to the last rib. So now you have a cranial boundary and a dorsal boundary. If you join this end to the area of the olecranon, that will be the triangular auscultation space. Are you following? Look at
Yes,
it.
sir.
Yes.
You can see it in any animal. You can see it in a live dog. You can do it in a cadaver. But these are the boundaries. And 100% question again on the next test, not the one on Monday. So these are very important things you need to know, because it is your job is to listen to the lung and write down your diagnosis before sending fluid to the lab. I hope this is what I have for you. Do you have any question? I'll be here and I'll be glad to try to answer it. No questions? Okay. Tomorrow at 9, I'm going to try to fix this Zoom and with the right, excuse me, right email address, and I would send it to you before the end of the day. Tomorrow, we're going to have the autonomic nervous system. Before I do that, I'm going to take the first 10 minutes to give you an orientation about how the logistic for the test on Monday, how we are going to run it. On Friday, I'm going to meet with the class president for the class help on getting the right specimens out in the lab so that we can tag it for you. Any question? Okay, have a good one.
Thank you.
Dr.
Dr.
Eljack.
Eljack.
Good day.
Bye-bye.
Dr. Eljack?
Yes.
Hey, it's Brianna.
Yes, ma'am.
You mentioned that, or how are you?
I'm doing fine, thank you.
You mentioned that you wanted to get together on Friday to do what again?
You see, because I'm gonna give you a list of what you need on Monday morning to have it set in the lab. You have to get with the class, the two groups, pick the right dogs. We need, I don't know, I put the list there. I'm gonna need about 12 dogs with the hind limb and the thoracic limb and the neck, and some detached thoracic limb. Well, you pick the best specimen so that the muscles will be very clear to tag and all the structure. I will give you that list on Friday during the lab.
This is for the exam on Monday.
Yes, because the student will be working during the weekend. On Sunday night, you have to assign some of your e-board or some member of the class, they volunteer. At the end of your review on Sunday, you get the specimen, you set up the table. I will show you how to set them up. And you put the specimen after you remove them from the bag. And because I don't have help to do, so we're gonna talk about it.
Okay. Just wanted to be prepared
Yeah,
for Friday.
you and I will just have a short break and talk about it.
Okay, it's okay if I give you my phone number so we can.
What did you say?
I said it's okay if I give you my phone number.
Yeah, no, you didn't. I asked you if you can send it to me together with
Yeah,
the right.
I'll just email it to you.
With the right email, just send those two, and I will put it in my contact information.
Okay, sir.
Okay, I'll see you tomorrow.
All right.
Have a good one.
All right. You
Bye-bye.
too. Bye.